Going to talk today about a recent column I wrote about trispecific antibody therapy in myeloma that I found that these results were presented at the summer meetings, and I found them to be interesting and exciting. So I decided to highlight these results in my latest column. Just by way of background, I think we all know that bispecific antibodies have become really important treatment modalities that we use in hematological malignancies, both lymphoma and multiple myeloma, and are also entering into solid tumor therapy arsenal as well. In myeloma, I think we have four bispecific antibodies approved, three of which target BCMA along with CD3 on the T cells, and one of which targets GPRC5D on the plasma cells as well as CD3 on the B cells. I've been using these in my practice, and I'm very impressed with the efficacy of these drugs and the relatively high tolerability of them. Patients really seem to feel good on them, and I would say most of them find them to be better tolerated than, say, multi-drug combinations that we're all used to using in myeloma. So, certainly a great time for novel myeloma therapies. And what we saw at the summer meetings was a presentation about a novel trispecific antibody called JNJ 5322 for short. Most of the patients had not received a prior bispecific antibody or a prior CAR, so they were more not commonly naive to those novel therapies. What was astounding about the results was the efficacy. The overall response rate was 100%, which, again, comparing across trials, looks to be more active than really anything, including the bispecific antibodies. The rate of complete responses in those patients was 70%, and very good partial responses 26%. So 96% of patients were getting at least a very good partial response. So the efficacy is really staggeringly high. So certainly very impressive results. When it comes to toxicities, the trispecific antibody did cause cytokine release syndrome in 69% of patients. They also tested giving prophylactic tocilizumab and found that that lowered the rate of CRS to about 20%. So that may be a strategy that is used more commonly to try to keep patients in the outpatient setting with both bispecific and trispecific antibodies. The progression-free survival efficacy looked quite good. 1 year PFS was 74% at all doses, and at the recommended phase 2 dose was 95%. These responses then would appear to be durable at least out to a year. I found this report to be one of the most interesting reports in hematological malignancies of all the summer meetings. It looks like the use of trispecific antibodies, and this one in particular, may offer real benefits, even over what we think are already incredibly impressive benefits seen with the bispecific antibodies. The investigators who presented these data indicated that phase 2 and 3 trials will be designed and performed in the near future. And so I thought this was, really exciting news and something worth paying attention to that story as targeted therapies go moving forward.